Introduction. Infective endocarditis is a serious infection of the inner lining of the heart, particularly the heart valves. It remains a life-threatening condition, even in the modern era of antibiotics and advanced cardiac surgery. In children, it is most commonly associated with congenital heart disease and rheumatic heart disease, but importantly, it can also occur in structurally normal hearts. If untreated, infective endocarditis is almost always fatal. Epidemiology. The epidemiology of infective endocarditis has evolved significantly. There is a growing proportion of healthcare-associated infections, largely due to increased use of central lines, prosthetic valves, and invasive procedures. According to recent guideline updates, the population at risk is expanding, particularly patients with implanted cardiac devices and repaired congenital heart disease. Etiology. The most common causative organisms remain Viridans group Streptococci, typically linked to oral flora, and Staphylococcus aureus, which is now the leading cause of acute, aggressive disease. Enterococci are often associated with genitourinary or gastrointestinal procedures, while fungal organisms, especially Candida, are more common in neonates and immunocompromised patients. Pathogenesis. The pathogenesis begins with endothelial injury. This is usually caused by turbulent blood flow, such as in congenital heart disease. Platelets and fibrin then deposit, forming sterile vegetations, known as non-bacterial thrombotic endocarditis. When bacteremia occurs, microorganisms adhere, colonize, and form infected vegetations. These vegetations protect bacteria, making eradication difficult and requiring prolonged antibiotic therapy. Clinical features. The clinical presentation varies widely. In older children, fever is the most common symptom, along with fatigue, weight loss, and a new or changing heart murmur. Peripheral signs may include Janeway lesions, which are painless, Osler nodes, which are painful, and Roth spots in the retina. In neonates, the presentation is often subtle, with feeding intolerance, respiratory distress, and hemodynamic instability. And notably, fever may be absent. Diagnosis. The diagnosis is based on the Duke criteria, which combine clinical findings, microbiology, and imaging. Major criteria include persistent positive blood cultures and echocardiographic evidence of vegetations or abscess. Recent updates, including the 2023 Duke-Hiskvid criteria, emphasize advanced diagnostics, such as PCR and molecular testing in culture-negative cases. Recent guidelines, particularly the 2023 recommendations from the European Society of Cardiology, introduce several important changes. First, diagnosis now relies on multimodality imaging, including echocardiography, cardiac CT, and even PET scans in selected cases. Second, management emphasizes a multidisciplinary endocarditis team, including cardiologists, infectious disease specialists, and surgeons. Third, selected stable patients may transition to oral antibiotic therapy after initial intravenous treatment. And importantly, early surgery is now recommended without unnecessary delay in complicated cases. Management. Treatment requires prolonged, high-dose, intravenous bactericidal antibiotics. Therapy is tailored based on culture results, but typically lasts 4 to 6 weeks. For example, Viridans streptococci are treated with penicillin or ceftriaxone, while Staphylococcus aureus may require nafcillin or vancomycin. Surgical indications. Surgical intervention is indicated when there is heart failure due to valvular dysfunction, persistent infection despite antibiotics, large vegetations with embolic risk, or infection with resistant or fungal organisms. Prevention. Prevention is critical, especially in high-risk patients. Current guidelines recommend antibiotic prophylaxis only for high-risk individuals undergoing dental procedures, not for routine use in all patients. Summary. In summary, infective endocarditis remains a complex, high-risk condition. Early recognition, appropriate antimicrobial therapy, and timely surgical intervention are essential for improving outcomes. And most importantly, prevention and risk identification remain key strategies in pediatric care.